Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatum min lisani yafqahu qawli. Thank you very much for allowing me to present in this August forum on a topic that is of a particular interest to me. I have no disclosures, but I strongly believe that surgeons are not superhuman and they cannot fix everything. Cancer is a disease which must be managed by people from different specialties, and a single technique, no matter how aptly performed and no matter which specialty it belongs to, will never answer every problem when it comes to cancer. So sarcomas are essentially tumors arising from tissue of mesenchymal origin, and there are different tissue types in different locations within the body, leading to a large variety of sarcomas that can be seen. We have genomic and transcriptomic signatures for some sarcoma subtypes, which help in their diagnosis and prognosis, but not for all of them. Any disease that is seen in less than 1 in 2,000 people is considered a rare disease in the Europe. And because things that are rare are not commonly seen, it can lead to lack of awareness, delay in diagnosis, and improper management. Sarcomas themselves are rare in incidence, comprise about less than 2% of all cancers within the UK, and 5.6 per 100,000 per year, much less than the cutoff of 1 in 2,000. Therefore, they are uncommonly seen, there is a lack of awareness, and they can have delayed diagnosis and improper treatment. So if I ask you to imagine any ball used in sports, many of you will think of different types of softballs, and there are many. And these have various sizes, shapes, and different colors used in different sports. And each sport will have their own set of rules and playing technique. You can't use one type of ball in a different sport subtype because it will be considered inappropriate. Similarly, sarcomas are heterogeneous with more than 100 histological subtypes, and the behavior that ranges on a spectrum from benign to malignant. And each of these has to be managed individually based on the biology and behavior. And it's not just a black and white classification between benign and malignant, it's a spectrum. And all of these 100 subtypes lie somewhere along the spectrum between very benign to frankly malignant. So this is something that we must take home, that soft tissue sarcomas are rare and heterogeneous. So how would you manage this 50-year-old man with a 4-month history of a painless swelling in the right shoulder, and an obvious lump is seen which is increasing in size and appears fixed to underlying muscle on exam with no axillary lymph nodes? Well, some of you might follow the oculobrachial reflex, which essentially means that the surgeon sees something that might need to be taken out and takes it out. This is a problem that if appropriate evaluation has not been done, can result in an improper management. And this is what we call an inadvertent excision. So unplanned excisions result in inferior disease control. Whichever term we use, inadvertent excision, Hope's operation, essentially it's a surgery done without any proper evaluation considering this a benign lump. It results in poor outcomes. The question is, where should sarcomas be treated? And we have evidence available to us from across the world that when sarcomas are managed at expert center, their outcomes are much better, both local recurrence and overall survival. Within the UK, there is a proper pathway and guidelines for management of soft tissue sarcomas, and these prompt for urgent referrals with screening ultrasound and sarcoma unit referrals. and has mandated discussion within sarcoma multidisciplinary team and treatment to be carried out by experts. And when the impact of these guidelines has been looked at 10 years down the line, they have resulted in a much decreased incidence of inadvertent excision and a much improved 5-year survivals. So early referral to sarcoma specialist centers results in better outcomes. We've talked about ultrasound, but it's a screening tool. It just stops at that. It's very cost effective and can differentiate between solid and cystic masses, can tell us that a mass can be potentially benign, but it's a screening tool. The real deal is cross-sectional imaging, which is, depending upon the location, MRI or CT scan, helps us localize the tumor within different tissue planes and allow us to plan surgery accordingly. Now, which of these 4 tumors is a sarcoma? Can we tell just by looking at the scans? And the answer is not all tissue lumps are sarcomas. So not every lump which may be cancer requires a surgical excision. We need a tissue diagnosis for us to better manage this tumor according to the nature and behavior. FNAC is not efficient. Core biopsy is what we should perform. It results in a very low risk of seeding and should ideally be in the direction of the future incision. It has got high sensitivity specificity and is accurate. And compared to traditional open biopsy, is very safe, results in much less incidence of complications and no increase in recurrence. So imaging, which is cross-sectional, and core biopsy are the cornerstones of diagnosis of soft tissue sarcomas. Retroperitoneal sarcomas are particularly challenging because of anatomical locations within the space that so many organs are there. They must be referred to specialist centers. Diagnosis again must be made by core biopsy, and surgical management by an expert within an expert center should be performed. Let's take the example of this retroperitoneal sarcomas. The extent of surgical management can be taking just the tumor out, all of the fat, or maybe taking tissues and organs from within the whole compartment. We can't select what type of management suits a particular sarcoma unless we know the pathological subtype. And we know from this large body of evidence that different tissue subtypes behave differently in terms of local recurrence and their risk of metastatic spread. So essentially, the extent of surgery will depend upon what tissue type or subtype this sarcoma is. And these decisions have to be taken within an MDT. All surgeons, radiologists, pathologists, medical oncologists, radiation oncologists, clinical oncologists, they must be experts within the field of sarcomas to be taking part in this MDT, and all must learn. All cases should be discussed. No question is trivial. Every extent of discussion will result in improved outcome, and all stages of management, diagnosis, treatment should be allowed to be discussed within a sarcoma MDT, and that is only how we can improve the outcomes of patients with soft tissue sarcoma. So to summarize, soft tissue sarcomas are rare and heterogeneous tumors. Um, the management at specialist centers improves outcomes. We must try and develop them. We must develop diagnostic and referral pathways, and just keep in mind that cross-sectional imaging and core biopsy are very important. There must be discussion in a specialist multidisciplinary team for sarcoma patients, and different modalities of treatment are used based on recommendations of the MDT, and we must record all outcomes for these patients. Thank you very much. I'm more than happy to answer any queries via email, Twitter, or a message on WhatsApp. Thank you. Allah Hafiz.